Rebonjour tout le monde, Saigo. Hello and welcome to this session of the MISC annual conference, which focuses on the impact of COVID-19 and Canada's resilient future. Je vais maintenant vous présenter notre modératrice, Amélie Quesnel-Vallée. Dr. Quesnel-Vallée holds the Canada Research Chair in Policies and Health Inequalities at McGill University, where she's a professor with an arts and medicine cross-faculty appointment in the departments of sociology and of epidemiology. She's also the founding director of the McGill Observatory on Health and Social Services Reforms and of the Consortium on Analytics for Data-Driven Decision-Making. Her research examines the contribution of social policies to inequalities in health over the life course and received numerous awards. She's also a two-time recipient of the Fulbright Canada Foundation Awards. I want to tell you before I let Amélie start and introduce our panelists that there is simultaneous translation today, actually throughout this conference. If you go at the bottom right of your screen, you click on interpretation, you can turn it off or click on French or English, the language of your choice. On a l'interprétation simultanée aujourd'hui. Il faut aller en bas, à droite de votre écran, appuyer sur Interprétation et vous pouvez choisir la langue de votre choix. Amélie, merci beaucoup d'avoir accepté notre invitation. C'est à toi. Merci.
Merci, Daniel, et bonjour à toutes et à tous. Je me considère vraiment privilégiée d'avoir le plaisir de modérer cette session aujourd'hui qui sera sans nul doute des plus stimulantes et éclairantes quant à ce qui s'annonce pour le futur de notre beau pays, alors qu'on espère sortir de la situation de crise au moins de cette pandémie. The past 2 years have been, without a doubt, the hardest of many of our lives, of our generation probably, and many have suffered through these years and many are still suffering through. And so our heart goes out to them. And I hope that this session can provide some amount of hope for the future, some thinking of what we may have gleaned from the experiences of the past that we may learn from and that we may apply to the future and in this most resilient future that we're all hoping for. So first, let me begin by introducing and thanking our panelists in advance who have joined us to lend their invaluable perspectives to this conversation. We'll hear brief remarks from them, and then I'll ask them some questions to stimulate the discussion about Canada's response to the pandemic and where we go from here. Charles Breton has been the Executive Director of the IRPP's Center of Excellence on the Canadian Federation since 2019. He was the Director of at Vox Labs, where he led the design of innovative public opinion research tools such as Vote Compass. His research interests include Canadian politics, comparative public policy, and public opinion research. Before pursuing an academic career, he was a researcher and journalist for current affairs programs on Radio-Canada, and he is a frequent analyst and expert commentator on Canadian politics and public policy. He holds a PhD in political science from the University of British Columbia, did postdoctoral studies at Vanderbilt University, and has an MA in political science from the Université de Montréal. David Kaiser, Dr. David Kaiser is a specialist in public health and preventive medicine at Montreal Public Health. Since 2018, he has occupied the role of Medical Chief of Environmental Health and is responsible for a wide range of issues, including housing, food security, transport, air quality, environmental noise, extreme heat, and climate change. David is a clinical assistant professor in the Department of Epidemiology, Biostatistics, and Occupational Health at McGill University. McGill represent a colleague here, and the École de Santé Publique de l'Université de Montréal. He is also director of the Public Health and Preventive Medicine Residency Training Program at McGill University. And last but certainly not least, Dr. Danielle Martin is the incoming chair of the Department of Family and Community Medicine at University of Toronto. Dr. Martin is grounded in her clinical primary care expertise. She is an active family physician whose clinical work has ranged from comprehensive family medicine in rural and remote communities to maternity care. She spent 8 years as a senior hospital executive, most recently as executive vice president and lead medical executive at Women's College Hospital, where she was also medical lead for the hospital's COVID-19 pandemic response. At Women's College, she led the establishment of Women's Virtual, Canada's first virtual hospital. The recipient of many awards and accolades, in 2019, Dr. Martin became the youngest physician ever to receive the FNG Star Award, the highest honor available to Canadian Medical Association members. So as you see, we have an all-star panel to lead us into this discussion on Canada's resilient future. And so without further ado, I will turn it over to them because that's what you came here to hear. So the panelists will share first prepared remarks of about 5 to 7 minutes each, and then we will launch into a moderated Q&A with some questions to stimulate discussion. So we will start with Charles, please.
Merci Amélie, merci à l'équipe de l'Institut, merci à Daniel pour l'invitation. J'ai vraiment hâte à la discussion qui va suivre. Puis là aussi, ça me rappelle qu'il faut que je fasse raccourcir cette bio sur notre site web. C'est une très longue bio, il me semble. Okay, so the title of this panel is COVID-19 and Canada's Resilient Future. And unless I'm mistaken, I don't think that was a question mark at the end of that. So the title assumes that Canada is resilient. So I'm not sure if it's optimism or clairvoyance. I think I share this view to some extent. Yes, Canada might be resilient, but I would argue that it needs to work in order to create the conditions necessary to be resilient. So I think we're going to talk about lessons learned here, I suspect, and with an emphasis perhaps on healthcare and public health. But in this introduction, I want to talk about another consequence of the pandemic, one that we don't fully measure yet, and one that's not about looking back, but very much about looking forward. So we're still fighting the pandemic. I mean, vaccination changed things, but the priority is still to protect the vulnerable, to protect the healthcare system. At the same time, and I don't want to use the word post-pandemic because I've been seeing this word since like April 2020, which we clearly wasn't in a post-pandemic world. And we've been reading even in the summer of 2020 post-pandemic world as if this reopening of the summer of 2020 was the end of everything. And so I don't want to use post-pandemic yet. But I think it's fair to say that we're slowly moving out of the most intense part of it. And so, for instance, the federal government is slowly moving from programs like the Canada Recovery Benefit to a more targeted approach, looking at what those programs should cost, what's reasonable at this stage, what is sustainable. So it's important at this stage to realize the financial situation we find ourselves in, the trends of debt. There are children behind me. The trends of debt to GDP ratios, for instance, in provinces were bad before the pandemic. They're not better after it, right? Provinces like Newfoundland and Labrador, for instance, were in a very precarious situation before the pandemic. And we're playing with the idea of cuts to healthcare as a way to right the ship. Well, that was a difficult task before. It's near impossible one now. So, I mean, at the same time, we're not facing a wall or a precipice, or Ottawa is in a better situation than provinces, even with all the spending from the pandemic. But sooner rather than later, we'll have to look at our fiscal situation at large, not just in Ottawa, but in provinces, in municipalities, and ask ourselves, okay, so who does what? And does everyone here has the revenue it needs to be able to do what is required of them, right? So outside of just how much spending should there be, I think we'll have to ask ourselves, is this the best way of doing things? Is there a way to improve how our federation operates, right? So the big question right on this front the first one at least will be healthcare spending and transfers from the federal government to the provinces, and what kind of strings should be attached to that or not. And so, yes, we need to figure that out, and we need to figure out how to improve the situation in long-term care homes to make sure that no one has to go through what we witnessed in the first wave of the pandemic, for instance. So yes, healthcare spending, but there are all other kinds of fiscal issues that the pandemic has either exacerbated or just obscured for a bit. So for instance, whose responsibility is it to pay for to adapt municipal infrastructure to climate change? What do we do as a country when the richest province, Alberta, votes in a referendum to remove a program, equalization, that's at the core of national solidarity? So to be resilient, and I looked definitions. I was going in a panel on being resilient, so I had to look for a definition to make sure I understood what it was. But so it's to be able to recover from difficulties, to adapt to shocks, but also to adapt to gradually emerging problems. So we've had a large shock that's still reverberating, and although a look back at the pandemic and a kind of forensic analysis of what worked and what didn't is needed and will inform what we do, I think that we definitely need to look forward and think about how we should change or reform our institutions in order to be able to face the challenges ahead. And that's what would make Canada truly resilient. So, je vais m'arrêter ici. Merci encore et j'ai bien hâte de poursuivre la conversation.
Merci beaucoup, Charles. Next up, we go to Dr. David Kaiser.
Thank you. Thank you for the invitation. And thank you to Charles for looking up resilience, because I forgot to. So now I have the definition in mind. I should be okay. So as Amélie mentioned, I'm a public health physician, and I work at a local level. So I'm at the Montreal Public Health Unit. And I think it would have been a little different a year and a half ago in terms of having to explain what that means. But I think COVID provides a window that is quite incomplete. So I think it is important still to come back to what does that mean, and what we're supposed to be doing out there is protecting the health of the population. So that during COVID time has been our contact tracing, has been our outbreak investigations. We're supposed to be preventing disease, which Charles referenced vaccination, and that is one of our fundamental strategies for preventing disease. But we're also supposed to be promoting the health of the population. That's a lot of what I want to bring to the table today. And in simple terms, promoting the health of the population means working on the fundamental root causes of health and well-being. And that's very, very different from the previous two strategies, where we're really targeting specific issues and often working in the short term. I thought a lot about what to bring to the table today, and in order to be able to refine structure and bring something I think will be worthwhile, I want to anchor that in my lived reality over the last year and a half. So as a public health physician, intervening during the time of COVID, and the place where I am able to anchor that for today is a prison. And the reason for that is that early in the first wave, we had our first big outbreak in a prison in Montreal, and it was a really chaotic time. There was a ton of stuff we didn't know about COVID. There was a ton of stuff we didn't know about what we were doing about COVID. And I remember very well in April of last year, walking into a prison for the first time in my life, when this outbreak had already started, and when there were already hundreds of people locked down in their cells and deprived of the basic necessity of life: hot water, soap, never mind getting out, having some room to stretch. And I anchor myself in that today because when we're talking about resilience, we're fundamentally talking about humans, we're talking about humanity, we're talking about people. And to anchor myself in the individuals that, for better or for worse, are going to bring us ideas that make better policy, but also that are going to feel the effects of our decisions or absence of decisions, of our policymaking or absence of policymaking, for me is really fundamentally, as a physician, where I want to place myself. And I'll come back to this in some of the discussion to come, but I think that also brings me to a place where I'm indignant. I don't want to be there. I don't want to be in a prison where people are locked in their cells for weeks at a time, because of the policies that we're putting in place and seeing that direct impact. And I want to connect that indignation, and I would say even to that anger that we can feel, but hopefully come out of it with something that is positive, that brings us further. And so I would just open on the next parts of our discussion with a question to anybody who is listening, watching, to invite people to connect to something that has aroused their indignation in the last year, something that has aroused anger, even that has aroused frustration, that's aroused distrust. And think about, we have students, we have academics, we have policymakers, we have physicians, with people who are all over the place on that spectrum, thinking about what didn't we do in the last 5 years, in the last 10 years, in the last 15 years that we could have done and that would have avoided the situations that arouse those feelings. And so that's what I wanted to connect to start, and look forward to the discussion. Thanks.
Merci, David. Those fighting words will certainly be picked up in the discussion to come. Danielle, I pass you the mic.
Merci bien Amélie, merci de m'avoir invité. Thank you all for coming, and I'm beaming into you today from the traditional territories of the Anishinaabe, the Haudenosaunee, the Mississaugas of the New Credit, to share my thoughts with you about resilience. And I want to begin by picking up on what Charles was saying, because I think although it may not be grammatically correct, I would like to posit that resilience is actually, in this context, not a noun. It has to be a verb. And that is really what I think you were saying, Charles, when you talked about the importance of earning the stripe of resilience, if you will, as a country, that we can't, this is not something that can be assumed. It is something that has to be actively pursued. And I think there are a number of quite concrete lessons for policymakers at the highest levels, as well as for those of us who work a little bit closer to the ground, about what resilience looks like and feels like in the post-COVID era. And I want to share three key lessons that I think can inform that resiliency response. The first is the lesson that all policy is health policy. And I think this is important not only because it's been obviously shown to be true over the last 18 months. Surely no one could have watched our crises in long-term care and across the country and not drawn lessons about what decisions we've made around regulation, around privatization, around workers' rights, around part-time work and precarious work, and around the ways in which we frame aging, and particularly which is a very gendered conversation, given the proportion of older people in long-term care who are women and the proportion of workers in long-term care who are women. All of that policy, it turns out, was health policy. And when 80% of the deaths in the first wave in this country occurred in long-term care, I think there was a moment of understanding that very deeply for most Canadians who may not have ever considered those policies to be health policies before. Similarly, it is impossible to ignore the reality that race, that income, that indigeneity, that all of the social determinants of health that we talk about, in our academic ivory towers, were so profoundly and directly linked to the likelihood of getting sick and dying in this country. And the number of frontline, intensive care unit physicians who have sobbed at seeing yet another racialized factory worker coming in through the doors to be admitted to the intensive care unit has borne witness to that. And David's experience in the prison is another such example. And so this is important not only because we now have a wealth of shared experience as a country upon which to draw when we make policy decisions in future in ways that are really tangible. When David talks about tapping into indignation, we can carry that feeling, those emotional responses, and our data and our scientific understanding of what's occurred in this country into those policy conversations. It's also, I think, important because one way to think about framing the public policy conversation is to explicitly frame it as a health conversation. It may not be that people really want to talk about equalization, but they probably are still willing to talk about health in the post-pandemic era and to think about what are the policies that support health for everyone, and the ways in which our health is intertwined with one another is deeply understood, I think, by all those of us who live here and indeed all over the world, and therefore becomes, I would hope, an opening for a new kind of conversation about what kind of policy is health policy and what does healthy public policy look like. My second observation, drawn from my own experience as a hospital leader throughout this pandemic, is, and as a huge advocate for virtual care and digital health, is that digitization is not the same as improvement. And this is something that I think we need to take to heart. Those of us, I've been working from home for the first time in the pandemic for the last 3 weeks, and I can't believe my low back pain. The notion that somehow taking systems that only sort of work and converting them to the virtual or digital versions of themselves is inherently improvement. I think almost everyone has come to experience that that is not necessarily always the case. And in healthcare, this has very particular ramifications because, of course, we've seen a massive uptake of digital health solutions and virtual care in this pandemic. I hope it is, as they say, a genie that won't be put back in the bottle. I hope that we've now reached the point of no return. And yet there is so much work to be done to transition from a world in which we basically just took systems that were a mess and converted them to a digital mess into a world where we're actually using digital health and virtual care to enhance the health of the population. Very concrete examples include, of course, that we have large numbers of Canadians who don't have access to broadband internet, can't participate in a video visit, but even when we're participating in healthcare by phone, if we're not careful, these can become barriers for people who most need healthcare to access it. Conversely, actually, the advent of billing codes, for example, across the country that permit physicians now to be paid to do digital and virtual visits has opened up the possibility of providing care to people at a distance, has massively increased access and increased the convenience of accessing care for many people who no longer have to take the subway or drive to a doctor's office and wait in the waiting room and all of this. I've had visits with my patients while they were waiting on the subway platform, while they were shopping at the grocery store, perhaps not, the most private environments for having a healthcare conversation, but the balance of power shifts. The balance of power shifts quite dramatically when we engage with our patients in this way, and when we think about people as consumers of a digital or a virtual service. And so the question is, how do we do that wisely? How do we do it in ways that reinforce continuity of care, that reinforce relationship between primary care providers and patients, and that add value, so that we're not simply talking to someone on the phone in order to tell them that they should probably come in for a face-to-face visit. And so this notion that digitization can be an improvement, but is not necessarily an improvement, is one that I think we need to take forward into our resilient future. And then finally, what I think is probably the most important lesson from my perspective in the healthcare delivery universe is the reality that pouring more resources into our same systems will not yield a different result. And we really need to think deeply about what that means as our premiers and our territorial leaders and our prime minister, battle it out over the Canada Health Transfer. And as, Charles points out, as people try to balance budgets at the provincial and territorial level and try to figure out, what are they going to pay for and not pay for in healthcare, let us not make the mistake of thinking that healthcare systems that are based on a hospital-centric view of the universe and a doctor-centric view of healthcare services are what we need for resiliency. We know the evidence is so clear that health systems that are based in highly accessible, equitable, high-quality primary care in partnership with public health are the ones that deliver the best results at the lowest cost. And so we need actually to use this transition moment into thinking differently about how we provide healthcare services in Canada, and to resist the temptation to build more buildings, more emergency departments, more operating suites, and instead look to community-based primary care delivery as the foundation of the better that we want to build back into. That, I think, is what will yield the greatest resilience, and it will be, as you have said, Amélie, the best way to honor all those who have suffered over the course of the last 18 months. Thank you.
Thank you. Thank all of you. So, Charles, j'ai entendu la question des responsabilités pour le financement des défis auxquels nous faisons face. Donc, talking about healthy public policy, which cuts across, as David knows well and as Daniel pointed out. Donc, ces défis comme les changements climatiques. Comment naviguer aussi ces décisions d'un point de vue de la fédération, alors qu'il y a peut-être des fissures qui deviennent de plus en plus évidentes dans la fédération qui était là avant. Je pense qu'un thème aussi que David et Daniel ont souligné, et que ce qu'on voit, ce qu'on a vu de révéler dans la pandémie, outre l'urgence médicale, c'est it shone a bright light on existing failures, fault lines, des endroits qui étaient boiteux dans le système. Et David, your indignation and call to action to call out those policies and their failings, I think is well, it is a way perhaps to channel some of the anger and frustration that we have seen in a productive way. And Daniel, I heard echoes of Virchow, who said in the 19th century that when he witnessed the typhus epidemic in the minds of Upper Silesia, that medicine is a social science and politics is nothing else but medicine on a large scale. So I'm throwing that out. Maybe Charles will want to react. And of course, the other threads that you brought together, that again, it's not because we put a gloss of digitization on something that it's going to be new and bright and better, and more money on in systems that are already faulty will not help. So I think you all set the stage, the table really neatly for the next step. So maybe I want to give you 1 minute each to perhaps respond to each other before we launch into the Q&A. And so letting you go at it, responding to each other, because Daniel had the chance to respond, perhaps to speak to. Charles, do you want to go ahead?
No, but I mean, I agreed with everything she was saying, and I think she was putting it very nicely, and especially at the end when she was saying, you know, the solution here is we cannot envision, or the only solution that we're considering here cannot be to only just put more money in the problem and think that that will just solve everything, right? And what's interesting here is that this saying that is directed both at the federal government, at the provincial government, and also, and I mean, that's something that I want to get at later if we get to talk about solution, is that we need the people making those decisions or fighting over the money, or they need to remember that at the end of the day, the goal here is to improve the lives of people, right? So and that should be the goal. That should be not a political win. The goal should be to help the lives of people concretely. And anyway, so again, I agreed with everything that was said. So I'm not sure that will make for a very contentious panel, but
well, maybe we'll have a consensus.
We'll get there. We'll get there.
Yeah,
for a change there.
Yeah.
We'll get there. No, I would have said, Amélie, and with what Charles just said, I would go straight to the next question, because I think it builds nicely. So, I mean, the question that was suggested to us was, what system vulnerabilities does this reveal? And I just want to pick up right on what Charles was saying about people. So I think first of all, I'll push back on the word reveal. I think we've been reminded of a bunch of stuff that we've known for a long time, and it comes back to that should make us angry. It should make us indignant. It should make us contrite. It should make us a whole lot of stuff. But there's not a whole lot that was revealed in the last year. There's a lot that we were reminded of, and things that were put under a spotlight in a different way. But for me, what that brings in terms of identifying maybe a unifying thread in terms of vulnerabilities is that we have systems that are not fit for purpose when they're under prolonged stress. And I think that should really scare us, because it's been a year and a half. And the climate crisis is going to be decades, at least, of really hard work. And so the systems that we have are unable to integrate people and benefit from collective intelligence, and especially in times of stress. And clearly with a year and a half, that's a prolonged stress. It's not to minimize that, but it's a stress that we're going to live again and again. And to make that a little more concrete, I think for me, there's two elements, and that's why I figured I would go straight to that from where we were at, because I think there's one part that's related to social exclusion. So there's a part, and you know, linking back to the individuals that we're thinking about. Danielle mentioned long-term care. I'm anchoring myself in a prison. We could anchor ourselves in an Amazon warehouse. We come to the same place where we have an immense gap between our systems, and we can define them however we want. I'm in a public health system. I'm at a local level. I'm fairly close to where people are, but I'm still very far away. So there's that gap that prevents us from having the feedback loops that would be necessary to make better policy. I mean, we are unable to go get the information that we need from the people who are going to live our policies. So I think that's one part, and it links to determinants of health, and it links to social exclusion. And then the second part is, after a year and a half, and I don't think we're the only organization that is living this, we have burnout, we have conflict between colleagues, we have mental health issues, we have organizations that are crumbling from the inside. And we've worked extremely hard to not have that happen. And we have people who are extremely dedicated, but we cannot protect the health of the people who are supposed to be doing the work in a crisis to make good policy, to make good decisions, and to be able to serve our population. And so I think, for me, it comes back to a similar issue, is that our decision-making mechanisms, the way that we work, is killing us. It's burning out the most dedicated, brightest individuals who we need to be there to move us forward, to not lose the institutional memory, to not lose the connection with, you know, what we should have learned from the last time. And so that's where it brings me, really, the idea of we're working for people, but we're also people working for people. And in both cases, we have systems that are unable to work in a way that allows us to do that without getting sick. So that's my little bit for vulnerabilities. And eventually we'll come to money, because we're talking a lot about financing, and eventually I'm sure we'll be able to disagree on something. But
well, we have a point there about how to address those vulnerabilities. So let's stay tuned. That's a sobering assessment, certainly, but one that has been well observed. Danielle, you're unmuted, so I'll give you next.
Well, I'd like to, maybe inject a tiniest bit of controversy by turning the question inside out, and asking, what we've discovered that we didn't know about our own greatness. And I would say that actually we've learned over the last 18 months, at least in the healthcare system where I have been functioning, that when backed into a corner with basically no other choice, we actually can do things differently. And that is a huge relief, frankly, for those of us who have been analysts of Canadian healthcare and observed over the decades how much everything we do looks suspiciously like everything we've always done, all the way back to the beginning. It turns out, actually, if you turn the heat up enough, we are capable of trying to do things differently. And there are so many incredible examples. And for every burnt out healthcare worker and public health specialist you show me, I can show you one who's been energized and connected to a sense of purpose in this work. And so both of those things can be true at the same time. And When I think, for example, about our experience of the vaccine rollout in my own community, which I was, have been very intimately involved in. And I will say that we started out exactly as you would expect a Canadian health system to start out. We built temples to immunization in convention centers and hockey arenas and hospital lobbies. And we were super surprised when everybody from the high income postal codes showed up and nobody from the low income postal codes was getting vaccinated. And actually, in a moment of clarity, we managed to use the most overused word of the pandemic, pivot to a different way of doing things. And through interactions with community leaders and community ambassadors, and through the hard work of community organizers who live and work in neighborhoods where vaccines are most important, and through religious leaders and through school principals in partnerships that would honestly bring you to tears in their authenticity and beauty, we managed to turn it around. And here in this most multicultural and diverse city of Toronto, we have vaccination rates that I don't think any of us ever could have dreamed of, including in those communities that most needed it, and most have good reason to question whether the healthcare system is truly in it for them or not, based on very accurate interpretations of historical interactions with healthcare institutions. So I would say that the flip side of that vulnerability is that there is capacity for creativity and doing things differently. The problem is, and I don't remember which of my colleagues talked about, if you crank the stress up for long enough, we have systems that are not built to withstand it. I actually am more worried about what happens when you remove the stress, that the regression to the mean, the pull to the way that we used to do it will be so strong and our exhaustion so great that we will simply be unable to do otherwise. And that is what most worries me, because there are seeds of greatness in the pandemic response that need to be nurtured and watered. And I don't know who's going to have the energy to do it. And so perhaps that is the vulnerability that I'm most worried about.
I just want to add something, because I think that's interesting. And there's another example of that, but I think the knowledge of being able to do those things is not going away, right? So I hopefully at least it's still there. And another example of something like the biggest boat that we didn't think would be able to move quickly. For instance, the Federal Civil Service was able to come up with all kinds of program of financial assistance like CERB on a scale that we couldn't think that they could come up with something like that quickly. There were problems with it, there were loopholes, but at the end of the day, they came up with a program that, for all intents and purposes, worked. And if there's one organization we wouldn't think would be able to turn around that quickly, it is the Federal Civil Service, and they were able to do that. So here again, I think if there is something there's a knowledge of being able to turn around quickly and do things to a scale we probably didn't know we could do. And again, I think they would also agree that they couldn't really work under that stress for another 3 years, but when it came to that they needed to do it, they were able to do it. So I think that's commendable, and something that we need to remember, that we're able to do that.
Totally.
Absolutely. So while you have the floor, do you want to share with us what you think are the most important vulnerabilities?
I mean, so I'm at a different level than my colleagues, because I'm not I wouldn't be able to say that I'm on the ground, in what I'm doing. So the one thing that I wanted to highlight, I'm not sure if I would call it a vulnerability, but one thing is sure is that many Canadians experienced in their everyday life what federalism was in Canada, more so than they did perhaps in their whole life. And that created problems in a way. So, I mean, more generally, there are advantages to a decentralized federation like ours, and we saw those advantages to some extent, right? So better responsiveness to local context, easier to tailor response to citizens' needs, possibility for innovation, and possibility for provinces to, imitate or copy what another provinces is doing that works. So we saw those, but we also saw that in a crisis like this one, sometimes there needs to be a more institutionalized, or at least more coordination that's going on in the sharing of information, for instance, and maybe a more coordinated, at least in what we project to the population, because the decentralization of the Canadian Federation created also problems for communicating with the population, and who does what, and who's to blame when there's someone to blame, and who's responsible for what. So there was definitely problems that the pandemic shed a light on, and we can get into the solution later. I'm not sure there's a solution to that one, but I think that clearly was put to the forefront.
So we need a better org chart.
Yes. But I mean, again, I want to make clear here, there was a lot of people, again, in my sphere that were arguing for a national response or for a greater role for the federal government. I don't think that that's the solution. I'm still convinced that a national response coming from the federal government would have been better. They don't know how to handle healthcare like our province does, and the province probably doesn't know how to handle healthcare like the local level does. So I'm not part of the people who thought that the federal government should have played a greater role than it did, but I think it's clear that in the coordination and the sharing of information, whether it's, I don't know, data on variants or what is a death related to COVID? How do we account for that? How do we count things? Just that. There was a lot of confusion and uneven ways of doing things across the country that I think created a problem for communicating what was going on to the population.
So there were features, but there were also bugs.
Absolutely. Yes.
Not all of them, not all the features became bugs and vice versa.
Exactly. Yes.
Terrific. And I think, David also pointed out information gaps. So all along, all around, at every level, certainly from the municipal all the way to the federal, information gaps have been uncovered. And I think pointing out also the importance of the appetite that Danielle mentioned for new ways of doing things. Suddenly, we were all laser beam focused on a common goal, this common fight against the pandemic. And so that improved the sharing because suddenly everybody was focused on that. So that's definitely something to bear in mind. Like, how do we keep focus on common goals, I think is something to think about. So you've highlighted some vulnerabilities, and now I kind of want to hear you on a twin answer on what are the root causes that you've seen identified of those vulnerabilities, and what would be low-hanging fruits for addressing them? What is like next year's big challenge, big push? Unmute, go at it.
So I will shamelessly trumpet the importance of primary care in our recovery. I would not call it a low-hanging fruit, but it is, the fruit without which we will starve for sure. And we are in this situation where, coming back to what you were saying, Charles, about what is the role of the federal government. The present federal government has a commitment that was in its last platform and also reiterated in its last throne speech, a fascinating commitment, I thought, for a prime minister to make, which was a family physician or primary care team for every Canadian. And, students of federalism might scratch their heads on that one, how exactly it is that we could possibly deliver on that promise all the way across the land. But there's a reason why suddenly there's an interest in primary care, and that is because it is, all over the globe, it has become clear that communities that had high functioning primary care systems did better, and that actually you can maybe do a first shot vaccine initiative by basically dialing down all of your hospital services and sending all the hospital workers charging out to the community. But by the time we get to the fourth booster, folks, we're going to have figured out how to do this in people's primary care offices, and we're going to have to be tracking it in the community. And so thinking about what it looks like to deliver on that promise of relationship-based primary care, a person who and a team who you identify as your first place to go, a trusted person who can answer your needs, large and small, and who will walk with you through the journey that you take through the healthcare system and through the journey that you take through your life. There is no better health intervention. There is no better healthcare intervention, period. And so we have to figure that out. And I believe that that is our next challenge, and where we have fallen down in ongoing screening for cancers, ongoing management of chronic disease, ongoing supports for mental health, and so many other health needs that were eclipsed by the pandemic. It was because we were not able to sustain our primary care services in the community, in large part, not solely, at the same time that we were running this parallel pandemic healthcare system. And I think that that is a lesson that we need to take with us and take very much to heart. It's not as fancy as MRI machines and hip replacements, but it actually has a much greater impact on human health at the population level.
Thank you, Danielle. David, Charles, who wants to go next?
All right.
David.
Thank you, Charles. Yeah, so I took, I went to find the definition of root, and I saw that root, taking that as
Such an erudite panel.
really going to its root and looking at radical causes of what we've lived through in the last year and a half, and I've talked, I think, given a couple of examples of how we've had difficulty connecting people to our system. So I won't necessarily go further on that than to say the out of sight, out of mind really explains for me a lot of what we've seen in the last year and a half. When we put the elderly away in long-term care facilities, when we use incarceration as a response to social problems, when we outsource the lowest paying jobs in healthcare to private agencies. We knew it was going to happen, but that stuff was out of sight, out of mind, and it's come a little bit back into sight. So I really think that's really important to see that as a root cause. It's a failure of democracy. I mean, it's an abject failure of democracy. But to come back to money and finances, I think the other thing that has to be mentioned when we're talking about root causes of what we've lived through the last year and a half is our economic system. It's runaway capitalism is a root cause of what we've seen in terms of obscene inequalities in income and wealth, and we can't expect to patch that with all due respect, primary care, with public health, with any kind of policy. If we leave that there as a root, we're always going to be trying to patch it with something that's inadequate. So I think wealth inequalities need to be seen as the one of the really fundamental root causes, and in very concrete ways. Food insecurity we saw increased over the duration of the pandemic. Families using food banks. We saw all of the relationships with other environmental exposures. So people who are in places where they're in inadequate housing, where they're exposed to air pollution, where they don't have access to proper transport systems. Those are directly conditioned by income, but also especially by wealth. And I think it's important to make the link with the climate crisis and the fact that a system that is predicated on infinite growth maybe doesn't have to include obscene wealth inequalities, but clearly does at the time, but certainly will lead to relentless exploitation of ecosystems and natural resources, which renders communities more fragile, which has profound implications for our ability then to protect, prevent disease, and promote health. So that's all very gloom and doom, but low-hanging fruit. So I really think that there's a branch that we kind of pulled down during the pandemic and that could snap back up, and we won't be able to reach it, which is a livable income for all. And I don't want to give it a more of a name than that, because I think there are many ways we could get at that. So it's not a specific policy solution, but an objective, which is that we've been ambitious during the past year, and we've seen a little tiny bit of benefits, but we've certainly seen what we get if we don't give people a livable income, and then we submit them to prolonged stress. So I think it really is a low-hanging fruit, but it's just that thing is going to snap out of reach. And the second thing I think is what Charles touched on, and Danielle also, which is decentralizing some decision-making to give communities more power over their immediate environments, and some of that is through investment. So high quality public transit, we know that is fundamental for allowing people to get to their jobs, to get that income to support their families. We know that massive investment in social housing is part of the solution, but some of it is also in the way we do government, democracy, and from bottom to top through things like participatory urban planning. So giving people the tools to make decisions about their environments that then make their communities more resilient when they're subjected to stress. So that's a little more hopeful, right? To pass it over to Charles, so it's not all doom and gloom.
Little wish list. So David, you might just get your wish with decentralization there. Looking like it in Quebec. Charles.
Yeah, I mean, I don't think what I was going to say was as transformative as what David is presenting here. I mean, I think that like the root cause of the bugs that decentralization in our federation, the decentralization of our federation created, the root cause here is the Constitution. So I don't think we're going to change that. But I do think that one of the root causes that's part of that too is that the way we do intergovernmental relations in Canada is not very institutionalized. Those things just happen behind closed doors, and we never know exactly who talks to who and when and at what frequency, and those things. For instance, just the Council of the Federation, where the premier talks to each other, is just basically trying to argue for things and present like a clear view from the province to the prime minister. There's not really a discussion going on there. So there was a lot of discussions like never before at that level during the pandemic. The first ministers, the premiers and the prime minister were talking to each other on a regular basis. So there's something there that happened, and same thing with health ministers, same thing with chief medical health officer. So there are discussions there that happen that I hope at some point get institutionalized in a way that also that the public sees, because I think that's important for the public to know that those discussions are happening and that there is a coordinating effort here to help them in their lives. So I hope that there are changes there. The problem with there are no clear hanging fruit, low hanging fruit here, because the problem is that intergovernmental relations, when they relate to healthcare or the fiscal federalism at large, is that politics always gets in the way. And there's no way around that. It is a political issue. It is a democratic one. And so, again, I think that's something that I said at the beginning. I just hope that everyone involved here at least agree on the problem and agree to sit down and try to fix it and think about what is the outcome that we care about here. Is not, again, it's not a political win, it's just to improve people's lives. So
again, the focus, common focus, absolutely. So, to a certain extent, some are saying that we are potentially on a cusp of a generational shift in policymaking that could be akin to that of the Second World War. We, in many ways, still do policy like it's a previous century. So there may be an opportunity here for radical change. And so I wanted to also hear you all on if there's a blue sky solution that you wish for in your wildest dream. And David, I'm looking forward to hearing that blue sky solution, seeing where you went with the low-hanging fruits. Go ahead. I'll leave it up to you to choose. So. Oh, now no one wants to go? No blue sky solution. You have the ear. There's potentially a decision.
Well, I'm going to ask David if you feel that, and Charles, given the conversation that we've had about the CERB and its successor programs, and the contributions of income inequality to the cracks that we've seen enlarge over time, whether this is the moment for basic income, and is that a realistic next step in Canadian public policy?
I mean, I do think, people, you have universal basic income advocates and people who are against it, both agreeing that CERB was not really exactly what it should be anyways. But I mean, it's clear, and again, like the effect of a universal basic income and the best way of doing it, or whether what are the advantages or disadvantages, those questions are still pretty much are not settled. But I do think, though, that it started questions, a discussion at least, as to a role for government that it didn't really play before, outside of unemployment and social assistance. So I think, again, like, once you've done it once, it opens up all kinds of possibilities, right? So people now, like, this is not a surprise if something similar to that is implemented in one way or another. People are used to it now to some extent, right? So the next policy that looks like that won't be as hard to implement or as hard to convince people that it's a good solution, because there was a COVID allowed for such a massive policy move.
So some inklings of it could be. It's been tried. It was in the books and in the minds of certain decision makers, and now maybe it is. David, you're unmuted. Do you want to go next?
I mean, I can go with blue sky, but I was hoping to hear Danielle's or Charles to inspire me, because I feel like my blue sky, once I was looking at that fruit, not sure where to go from there, but I'm happy to start the ball rolling if that be, Charles, I see.
I don't have a blue sky, again, because I said politics always gets in the way in my field, so it's hard to blue sky it.
So I'll go ahead then. I think I'm going to come right back to the start and look at the people we were talking about, the people we mentioned, the individuals that Amelie, you started by saying the people who have suffered the most over the past year and a half. And I really think that if we want to use this opportunity to build something different that will be resilient, whether that's a noun or a verb, people need to have agency. And I'll come back to the emotions. I think we really need to take this opportunity to validate people's emotions, to go right to the individual level and to say we need to validate the anger, the frustration, the distrust, which is really something that has grown even as the pandemic is waning, and that we can't afford to just leave there. And Danielle said it at some point, not exactly the same words, but I can't remember your exact words, but for me, going from the individual to the collective and recognizing that this is the first time for most of us that we have a truly collective trauma that has impacted the entire country, the entire population from top to bottom. And there's been metaphors, that are good and bad, or right or wrong, of we're all in the same boat or we're in wildly different boats. In any case, we've been in the same storm, and it's really that the individual emotion is one thing, the collective trauma is an incredible opportunity. So for me, that's the blue sky, is to say, if we are able to be honest and look at each other and say, why are we feeling the way we're feeling? Bring that to the collective and use it to radically retool our systems. And Daniel said, the seeds are there. And I'm not sure that I want the heat turned up too much more, that I want to be under this much stress for a whole lot longer. So maybe we can find other ways than external stress to nurture that. And I think part of that is really looking at the way we collaborate, looking at the way we include, and that can be between government and citizens, between levels of government. Charles mentioned sharing information. There's, that can be rendered concrete in a million ways, but we need to be able to go all the way to how we're feeling and bring it back to how we work. And I just want to leave it on a very concrete example of what's been done in the last year, which is vaccine development. And the vaccine development was a radical shift in how to do business. We didn't leave behind capitalism. They still cost money, and there's still wild inequalities in their deployment. But we got vaccines extremely quickly with technologies that we had around but hadn't used, because people worked in a different way, because across countries, across jurisdictions, across public-private, people broke down barriers and worked in a radically different way. And I think if it can be done for something as complex, as political, as wildly tainted by the profit imperative as pharmaceutical development, that's a blue sky. We can do it for anything.
I love it.
That's that.
So yeah, bring on the compassion, the empathy, the caremongering, and take the energy that we put into developing in record time vaccines that work amazingly well to other challenges or other social and health challenges. Danielle, tall order to come on top of that.
Well, my question about the basic income was just my blue sky. I mean, I really think, it is probably the biggest learning of the whole pandemic, that we have the capacity to respond on the scale that we did, at the speed that we did, to stabilize the fundamentals for people. And I just don't see how we ever go back from that. As I bang my drum of primary care as the most important thing you can do in a healthcare system, there's absolutely no doubt that addressing poverty is the most important thing you can do for people's health at the level of the social determinants. I mean, it is the number one determinant of whether we get sick or not. And as I said in my opening remarks, we have seen that now. Each one of us has seen that in really impactful ways. And so that leaves its mark on the social consciousness. And I hope that, at the very least, a radical rethink of our income support programs in this country is a legacy of the CERB and of the income support programs of the pandemic. I don't see, if we don't take that opportunity, it really will be a shame, I think, for the future health of Canadians, because the gig economy is not going away. So we're gonna have to modernize these systems to match the realities of precarious work for the future, and to turn the page on that chapter. That was a pandemic program, and now we're going to go back to the way that we deliver services when we're not in a pandemic would be a real shame. So that's my hope for the blue sky.
So yeah, not going back to regularly scheduled programs as they were. But I think beyond poverty, I would highlight that what we've learned is stability. And that is something that the income support, the minimum income programs, experiments that have gone on in Canada have shown this stability was something that people really yearned for, and that they were able to provide in this environment is it's just a testament to this. So for the last about 10 minutes that we have left with you all, I wanted to ask you just open-ended question. Is there anything that I didn't ask you that you wish I had? We exhausted all the options.
I mean, Amelia, I'm curious to know what you think we missed. You actually study these questions. You could just as easily be on this panel as hosting it. So what would you have said if you were in one of our Hollywood squares here?
I would definitely have picked the income support programs. So I think this is really the learning that we've had. And yes, there are squibbles about this wasn't really minimum income guarantee, but ultimately it is what, to people, it's what it felt like. I did also want to highlight, having a lot of colleagues who were in the States, how equitable our vaccine distribution rollout was, and disciplined, I guess. And so I thought also that was an extremely interesting and something that we learned from the past. So evidently, I recall, the early days of H1N1 and the panic or the craziness in Quebec, and then the next day it was kind of fixed already in the big urban centers. And I think we learned from that and we applied it, and the precision with which it was delivered. And of course, notwithstanding, and then the rapid realization from people on the ground, public health folks on the ground who knew their systems and their people. And this happened, what you described happened in Montreal as well. And shout out here to some of our actually graduate students in public health at McGill who rolled out a program, We Can Vax, in Parc Extension, to really amp up the vaccination uptake there. So really those grassroots, we can do it, get yourself up by your bootstraps and do it, but because of the knowledge of the experience on the ground. So recognizing that, and to David's point, hearing people, listening. So the connections, I think the connections were never so clear between the ground and all the tous les paliers, comme Charles, all the way to the federation. People have been listening, but then remembering also that this is a lot of pressure to be under, to listen that much, I guess. And so how can we routinize those channels of communication where we get, and this is a point that Charles made also, we don't have these processes laid out, and that is, we're beyond 150 years. So what? Let's get with the times and make sure that there are these regular touch points, and that we can learn about not just how to pronounce epidemiology and learn a little bit about our immune systems, but also our political system. I think this was also something that came out that was really fantastic to watch. David, you've unmuted.
Yes.
You unmute, you're called upon. So
as long as there are,
you're going to get the last word.
As long as there are 2 minutes left. So you asked, is there a question you didn't ask us? And Danielle, I really appreciate that she had you turn that around on you. And I think what I would do is also turn it around on the participants. And there's 3 of us here. We've brought our perspectives. There's 4 of us with you. We've brought our perspectives, and I think there are things we're clearly convergent on, and then a diversity of perspectives that are super important. And for me, the question that could be asked is to the audience, a question which goes with what you just said. Every journey starts with a small step, Amélie? So why after 150 years do we accept that we have systems where we don't talk to each other? It's because we allow that to happen. So the question to participants is, radical collaboration has to start with a small step. So who are you going to call? Who are you going to write to? Who are you going to call? And ask, how's it going? And connect to in a real way to the pandemic and what we can learn from it. So that's what I would leave as a last question.
So who's your decision maker that you want to reach out to?
I'm actually gonna call my mom, I think. But if anybody wants to reach out to me, I'm happy to.
Thank you,
Thank you very
David.
much. Thank you, Danielle. Thank you, Charles. Thank you, Amélie.
And thank you all three so very much for being here with us today and sharing your insights. This has been really a tremendously engaging conversation. I could have, let you just run it as a moderator. It's a pleasure to work with you guys. And thank you all, everybody who joined for this great conversation and who will join, because this recording will be made available for future use and perusal. So on behalf of MISC, we hope that everyone watching here today enjoyed today's programming, not just this panel, but the whole programming, and that you will join us tomorrow as well for great conversations like this. So thank you all so very much for being here with us today, and all the very best.
Merci.
Thank you.
Merci.
Thank you.